Yeah, stop.
The slides ourselves, or is it?
Yeah, so I've matched, so you'll be able to control everything with this mouse.
Oh, okay.
So,
Hi.
hello.
I had to.
I'm gonna have you sit here because just so the microphone can pick you up.
Were you talking about me? Okay.
This is my microphone from home that I use to record music. So it's really good. I mean, you can probably pick up sounds from there, but
Are you? So we're gonna rotate. Who's gonna be near the microphone?
no. We just need to be close to it.
So then, can Kyle be heard from there?
Yeah.
Okay.
We did test.
I'm just saying, I just wouldn't want you
Okay.
over there. And
Sure.
Pam's just sitting there because she's feeling bossy.
I was gonna say,
She's feeling,
she wants to be heard too.
she's feeling large and in charge.
We want to hear your comments.
When do we get the comments ahead of time? Do we not get them now?
What'll happen is that we'll get, let me just reply to this email real fast. We're gonna be getting messages on the fly that we can talk about. And then people obviously can contribute.
Okay. You run to the bathroom. I just had two Diet Cokes.
They're listening, by the way.
Okay.
Hi, Edgar. It's Veronica. Let me know if
Hey.
you need anything.
Okay, let me just, we just want to make sure everything's in order here. I did have a question about the, hold on, I'm answering an email real fast.
Veronica,
Okay.
it's Colleen, you could probably make Edgar like the co-host or the host.
Okay.
My question was, when I project my slides, on my laptop screen, there's like the notes view, but then on our large screen, it's the PowerPoint presentation. Now, if I do the share screen option, will you guys see these notes?
Colleen, do you know the answer to that?
Potentially not, as long as you go to like design and the slideshow. We can test it if you want to share it now.
Yeah, we can. I just clicked share, but which one do I pick? Screen, okay, screen. Oh, it looks like I have the option of sharing different things.
Yes.
So let me test it.
Yeah, then you would want to go to like design and then, yo, perfect.
What do you see right now?
Your
I don't
slide
see any
presentation.
notes, but I see like next slide.
Do you see the PowerPoint? Does it fill the screen?
It
Hold on.
shows, it's like 3/4 and then you see the next slide.
How about this? We're gonna have to switch it out.
Yes, that's fine.
Oh,
That's
that's
better.
perfect. That's
Okay.
better.
All right. And then you can hear us okay?
Yes.
Okay. And then can you see us, I guess, is the next question.
I cannot, I just see your
Oh.
PowerPoint presentation.
Do I need to do anything to fix that?
You have to start your video. There's like a button at the bottom.
I'm clicking on it. Let me see. Start video.
Now we see you.
Okay, great. So what'll have to happen is I'll have to take it out of presentation mode each time I load up a PowerPoint.
And then who in the room is going to be speaking primarily?
It'll probably be me.
Okay. Yeah, just as close as the mic as you can get to, but I mean, I can hear you currently.
Hold on a second. I just did something totally wrong here. Yeah.
Colleen, we did test a mic a few days ago, and the person in the back could be heard pretty well too.
Oh, nice.
Yeah,
Great.
it's a pretty good microphone. This is why I had to move the OUs. So this one's getting covered up.
Hey guys, can you hear me? Tom.
Hey, Tom.
Hi, Tom.
All right, we're gonna. So I see that you're going through the last minute steps to see if it's all working for you.
Yeah.
Oh,
So Tom's on.
hi Tom, how are you?
Good. Let me make sure I get all my functions and features going here. My chat.
So Tom, my plan was basically, I have some questions that I'm going to be asking the group and to the presenting fellows, but you told me I should keep an eye out for messages that are coming through. Is that right?
If you can, yep. If you
Where
don't.
on the screen do I look for that? Because I don't see that.
So go down to the bottom and find the little thing that says chat.
Mine's at the top, it looks like.
Okay, top.
Oh, wait, maybe.
Yeah, go back up to that. Is there anything that says chat?
I see mute, stop video, manage participants. There's more. Chat. Got it.
Oh, great.
So I'll just stick that over here on the bottom right.
Yeah, and so you can see that while you can make the box smaller or bigger, you can't actually make the font bigger or smaller. So that.
What is that noise?
You just turned on the.
Oh,
Sorry.
sorry.
Turn on the AC. Good.
Well, you should have seen us last time. I had 2 microphones going and the feedback was incredible.
We're next to an airport. Oh my gosh.
And so why don't, before you get going, I'll just introduce that it's being happening at your spot. I'll do some announcements and housekeeping.
Okay.
And then I'll turn it over to you. And if you want to introduce who all you guys are before you get going, that'd be great.
I'll introduce everybody and then we'll get started.
Cool.
And the goal is basically to kind of jump in quickly with the survey results, and then we'll present one article, field questions, present the next, field questions, and then further discussion from there.
Which article are you going to do first?
We're going to do the implementation of ERAS for your guys specific, the SGS meeting.
Okay. And then when do you expect the long discussion really about sort of the ramifications? Is it going to be kind of at the end, or do you think it'll come after the first paper?
Honestly, I think it'll probably happen throughout. I was kind of going to let the things sort of organically develop as we talk about it.
Cool. Yeah. So, Lena's not coming. Megan will or not be?
I don't think that they did. I don't think they did.
Oh, okay. It really is.
They did.
Oh.
It's getting better.
No, I just was trying to make sure that we're not on mute right now. No, I just thought maybe until we get going, and thought maybe Rahel might want to come in. I'm going to mute myself for a few.
Okay. He's muted.
Okay.
But we're
This
not
is
muted.
neat. We're not.
We're not muted.
Not that you were gonna say anything.
Okay. Well, let's do this one. Do you have a plug here? For the phone?
So Colleen,
These are bags.
Yes, hi, Veronica and I are on. How
no
are
problem. I'm just checking in. So the usual thing is that you guys as the hosts can see all the people that are waiting in line, but we will only see them come in when they when you let them in.
you? Correct. Yeah, you give us like the green light. Okay, let everyone in.
Okay. How many are on hold right now?
6 people are waiting.
Okay, great.
Yeah.
It's okay. It's still 5 minutes.
I know.
Still
I got
5
it.
minutes, but we had like 42 respondents saying they were going to join. So at least.
Yeah, I thought we had 44 registrants.
All right.
Oh,
Ian's
44.
gonna tweet right now.
Here, that one box down so that I can get this.
Are you gonna be on mute, Tom, or are you gonna be quiet?
I'll mute in a second.
Can you hear me?
Yeah. Hey, Steve.
Hey, good morning.
Good morning.
Hello.
Hey, Edgar, was that you saying something there?
Oh, I just was replying good morning to, I think it was Steve.
Yes, it is true. Sometimes your mic kind of diminishes just a bit.
Yeah.
Okay.
Okay.
That's great right now.
Okay. If it becomes problematic, just shoot me a message, and I can switch it to a different mode where maybe that won't happen. I'm not really. There shouldn't be a lag.
No, I think it might be just when you first start speaking, or maybe I don't know. It you try it maybe is too smart for us, the microphone.
Yeah. Okay.
Oh,
It's working.
I guess you're Holly. I'm gonna download all your pictures.
I was gonna say Holly has access to your phone.
Wait, it's so boring.
Hey, Steve, Tom here. You want me to do the same thing where I go ahead and get things rolling, and then you chime in whenever you're. Does that make sense?
Yeah, that's fine, Tom. I have a case coming up where I'll have to leave like 10 minutes to the end of it. So if we're still going.
All right. I'll just plan on you, if you're there, hearing something from you. If not, I'll start it up and wrap it up.
Okay, thank you very much.
Yeah, no problem.
So was that Steve?
Mhm.
Okay, great.
Tom, I would also make an announcement. The past journal clubs will be on the FPMRS net website. It's supposed to be available today.
Okay.
Under media tab, journal club section. So
Okay, cool.
And did you all have plans on announcing the next journal club at this one?
I think I'm going to. Yeah, we learned that Michelle Morrell, and we'll do it. Yep.
Yes.
And I'll post that on the FPMRS and OG sites on Monday.
Perfect.
Okay. Is that Veronica?
Yes. Hi.
Hi, Veronica. How are you?
I'm fine. How are you?
I'm good.
that's Tuesday, December 3rd. You have the time, right, Tom?
At 5 p.m., right?
That's what I remember. Yep.
Pacific time.
Yes.
Great. Hi, Steve.
Alison, thanks for doing this.
Absolutely. Yes. My pleasure that Eddie's doing it.
I was going to say yes.
And it's a whole thing. It's wonderful.
So it's time.
Everything.
Oh, okay.
Should we let them all in?
Okay.
Yeah, might as well.
Okay.
All right, guys. As I'm looking here, I'm seeing people coming into the chat room and into the online journal club. I'm just watching and seeing how many people come on in, and I know that Colleen is adding people as we speak. But welcome everyone to our next iteration of the sort of joint sponsored from FPMRS, the journal, as well as OGS, our sort of national, international journal club. Hey, Cassandra. I just wanted to sort of get things going by just not having a couple of announcements and housekeeping, and then we can get going. Just so everybody's aware, you can see on your screen if you're looking online that we're kind of listening in live to the University of Oklahoma's Journal Club, and we're both passive as well as active participants. You probably you got the articles posted on the announcement. So hopefully you've had a chance to at least look at them and read them. You should be, when you're logging on, notice that your microphone is by default muted. That's great. That just keeps the noise down. So, you know, you may want to say something. If you do, unmute yourself and say something, or, you know, raise your hand. You can see in some of the features that you can actually sort of indicate that you're interested in talking and raising your hand, and we can try to mute and unmute you. This really, while it's going to be a discussion of the paper by the folks at Oklahoma, it really is meant to be more of a discussion rather than a lecture. So we're looking for some way to have some engagement with you all. I want to let you know that the authors of these papers have been invited, and some of them are actually on the online right now. So we may get some even more useful insights and feedback as we go through these discussions. I've mentioned using the chat feature. So again, at the bottom of your screen, or maybe the top, you can pick up the chat feature. And I'm going to chat something right now just to let you know how this works. And you can sort of see me saying hello to everybody. And yeah, that's it, sort of how this kind of functions. I want to let you know that we've already scheduled our next journal club, which will be on December 3rd, which will be 8 p.m. Eastern Time or 5 p.m. Pacific Time. And the folks at Kaiser UCSF in the Bay Area are going to do that. And we are very happy that they will as well. And that information will be also posted on the OGS website here in the next couple of days. And I think that's it for mostly our intros and housekeeping. I'm going to turn it over to the folks in Oklahoma who can introduce themselves and say hello and get going. So I'm going to mute myself for a while, but I'll leave myself and us here in Portland on this and let it go.
Okay, great. I'm assuming everybody can hear me okay. And my name is Edgar LeClaire. I'm one of the Eurogyne faculty and program director here at the OU Medical Center. And thanks for having us. And we're looking forward to a lively discussion. We're looking forward to feedback from the group. So I'm going to start off by just doing introductions. This is Kyle Mock. He is our third-year fellow, and he will be presenting the implementation of a Eurogyne-specific ERAS pathway paper for us. Here we have Dr. Trang Pham, who is our first-year fellow, who will be listening intently. Dr. Lishan Kiros, who many of you know is our section chief and my partner. And then we've got Dr. Holly Wong, who is our second-year fellow, who's going to be presenting the same-day discharge after robot-assisted signal colopexy paper. And so the topic of today's discussion revolves around ERAS and same-day discharge. And when you kind of look at the picture overall in terms of ERAS and same-day discharge, I think the FPMRS field is in the midst of an adoption curve. And I suspect that different facilities and different practitioners are on different parts of this curve. So if you're not familiar with this curve, from a great book by Jeffrey Moore called Crossing the Chasm that essentially explains how innovations essentially filter through a field and become widely adopted. And I think many of us understand that, you know, the colorectal surgeons, the GI surgeons were the original innovators of the ERAS pathway. And this has now crossed into other surgical domains in hopes that this is going to improve perioperative outcomes, patient satisfaction, and frankly, cost. But when I realized the topic of discussion for this journal club was going to be ERAS and same-day discharge, I couldn't help but wonder where we are as a field on this curve and where we are as individual practitioners on this curve. And so what I decided to do, and I thought it'd be interesting, was essentially to get a snapshot of the registrants who were going to participate in today's journal club with us, just so we can contextualize our discussion to what is actually happening out there. What is our experience with ERAS and same-day discharge? So I developed a survey asking basically the registrants. It was an 8-question survey. I got about a 55% response rate. So this is from you in the audience and the group who's providing me this information. Like I said, I thought it'd be very interesting to frame our discussion with what everybody's experiencing. And let me just move this chat screen real quick so I can see. So of the 24, when I asked the question, has your primary surgical facility implemented an ERAS protocol, that was just over half. So I got about 54% of respondents who said that their facility had implemented a protocol. The next question was, when I asked what percentage of your surgical patients actually undergo ERAS, I got an overall average of 52%. It was a slide rule question where the respondents get a slide along and mark the percentage. And what I did was I subcategorized it so it would make a lot more sense. But essentially the majority, 40%, reported that 75 to 100% of their patients underwent ERAS. But remarkably, about 20% said that 0% of their patients did. And now looking at essentially the perceptions in terms of an impact on postoperative or perioperative outcomes. The interesting thing here was 25% of respondents reported strongly quite a bit, but just as strongly we had participants say that they did not know. And then the anchors here may be very familiar with to most of you because these are just right out of the PFDI, that quite a bit, moderately, somewhat, not at all. And so you'll find that this is a recurring theme with some of these other questions. Like the 2 most common answers when you asked about ERAS and same-day discharge was quite a bit or I don't know. So how much has ERAS positively impacted your patient satisfaction measures? Once again, about 37 participants said that they did not know. The next most common answer was quite a bit, which is 20%. How much has ERAS reduced perioperative costs at your primary institution? So again, this was another big focus, and a lot of data has been procured looking at this. And the vast majority of participants reported that they did not know what the effect was on their operating costs. In terms of what procedures people are sending patients or planning to send patients home on same day for, not surprisingly, for anterior, posterior repair and sling, we were in the 90s. But the drop-off with vaginal hysterectomy is notable. And as you continue down, you'll notice that for sacrocolpopexy, the number dropped, things sort of dropped again to the 30% range. So about a third, it seems like, of sacrocolpopexy being performed by the registrants who are participating in this journal club have a priori plan to go home the same day, which is interesting. And in terms of patient enthusiasm, I was curious to see what providers' perceptions of patients' enthusiasm for same-day discharge was. So here I asked, based on your clinical experience, how would you rate interest in same-day discharge for major procedures? And it was lukewarm. Most responded that they were somewhat interested. There was a component of, there was a proportion that said that they were extremely interested, but there were responses that said that they were not at all. So I guess I got a sense from patients that may be a little bit reticent or hesitant for same-day discharge. As there was a final qualitative component to the survey where I was interested to get information regarding thoughts and concerns. I kept it very broad just to see what the registrants would say about same-day discharge ERAS. And there were basically 5, this was by no means a thorough thematic analysis, but the 5 sort of key takeaways from what I'd read was most commonly there was age-related concerns, patients north of 70, 75, concerns about sending them home the same day. There were other concerns about perioperative outcomes in previous studies not really being demonstrably improved when compared with ERAS. And so there was a concern that, if this doesn't really translate into improved pain or improved satisfaction, then there was some skepticism there. Geographic distance was another concern, especially out here in the Midwest. For us, we get a lot of out-of-town patients who not uncommonly live 2, 4, 5, 6 hours away. And so same-day discharge can be a little bit concerning for those patients. And then interestingly, there was a note that it was, this is an aggregate intervention. And so there was some commentary about needing to unpack ERAS into its individual components and really testing the merits of each individual intervention on its own merit to really better understand what we're doing with ERAS as opposed to looking at it as an aggregate intervention, which I thought was interesting. And then finally, and not least, the implementation task load. So there were a lot of comments on, yes, it's a great idea, but getting everyone to share the same mental model, to get it off the ground, and to actually implement it in actual practice was the biggest hurdle that a lot of people envisioned. So that's it. That was kind of the gist of the survey results, and that's kind of at least a core sampling of what people are thinking in terms of ERAS from this obviously limited sample. So understanding that, I think we'll move on to our first paper here. And so let me just load this up. Oh, yeah, we'll get to the comments here. Yeah, they're just, okay, we'll get to those. Okay, so we're gonna start with Dr. Mock.
I don't think any of the comments yet or have anything to do with what's going on. So
Right.
we're just kind of
They're just-
talking on the side.
More confirmatory comments.
Yep.
Okay. And
Stimulating thought.
let me see, are you guys able to see, let me get this fixed. A quick second. Okay, are you guys good?
Yes.
That's good.
All right, so I'll leave it to Dr. Mock at this point.
Thank you.
Yes.
Okay, so the first article that we're going to present is from the Gray Journal. It is titled Implementation of a Urogynecology Specific Enhanced Recovery After Surgery, or ARIS Pathway, and it comes from a study by the University of Pittsburgh. Just a little background about ARIS. It is intended to enhance recovery and improve perioperative outcomes. There are several key components that have been developed, such as patient education, optimizing patients preoperatively, avoiding preoperative fasting, carbohydrate loading, careful fluid administration, standardized opioid-sparing anesthesia, prevention of post-op pain and nausea, and also early mobilization. So it was, as we said earlier, it was originally developed for colorectal surgery patients. It has been adopted into other specialties, including gynecology. And the best studied gynecology population has been oncology patients. And studies on those patients have shown a decrease in hospital stay, faster return of bowel function, less narcotic use, improved pain control, and higher patient satisfaction, although those studies were on patients who were undergoing laparotomies. So the question that this study addressed was, can the benefits that have been seen in previous studies be expected to be seen in a urogynecology patient population where the surgeries are typically elective and the approach is typically laparoscopic or vaginal, and the stay is typically already just one overnight stay if the patients are being admitted. So the objective of the study was to evaluate whether implementation of an ARIS pathway would facilitate reduced length of admission and increased same-day discharges after pelvic floor reconstructive surgery. And the hypothesis was that ARIS implementation would increase the proportion of same-day discharges by 18%, and 30-day complications would not increase by more than 10%. Study design, it was a cohort study with a retrospective control group and a prospective intervention group. Patients undergoing surgery at the University of Pittsburgh FPMRS practice were treated with the ARIS protocol, and several observations were recorded, including length of admission, same-day discharges, complication rates within the first 30 days after surgery. This group was compared to the similar group before the ARIS protocol was implemented as a control, and the same data was compared. There was also an assessment of preoperative patient compliance with the ARIS protocol and postoperative patient satisfaction, which was assessed in the post-ARIS cohort only. And there was a standardized criteria for discharge that was established, including a pain score of less than 3, ability to tolerate juice and crackers, no nausea or emesis, ability to ambulate independently, ability to spontaneously avoid, or a plan to go home with the catheter, and a wake score greater than 9, which is a standardized anesthesia score. This is just a table that shows the different components of the ARIS protocol that was developed at Pittsburgh, which was a combined protocol from other specialties. It included a pre-op assessment, either in person or by phone call, recommended exercise daily after the surgery, carb loading on the day before surgery, and allowing clear liquids up until 3 hours prior to surgery time. Preoperatively, they also gave 3 oral analgesics. They also gave medications to prevent nausea and vomiting, and there was no IV fluid given preoperatively. Intraoperatively, they avoided opioids, and they gave IV fluids carefully to maintain eubulimia. Postoperatively, they avoided using PCAs, and they also did postoperative phone calls on postoperative day 1. So who were the subjects? They were women who were undergoing elective major surgery by surgeons at McGee Women's Hospital at the University of Pittsburgh, which is a tertiary care institution, and the groups were before and after implementation of a urogynecology specific ARIS pathway. The pre-ARIS groups was all consecutive patients who had what was considered a major elective procedure from January 1st, 2016 to June 31st, 2016, and the post-ARIS group was similar with 2 less surgeons included. It was from February 2nd, 2018 to July 31st, 2000. Actually, that should be 17. So approximately the same populations. So the inclusion criteria, it was what was considered a major pelvic floor reconstructive surgery, either vaginal, laparoscopic, or obliterative. Patients were excluded if they were undergoing just an anterior posterior colporphy or sling, and they also had a washout period where they excluded the patients in the 8 months immediately before implementing the ARIS pathway, because there were meetings going on where the ARIS protocol was being developed and they were concerned for crossover. This table just shows baseline characteristics of the 2 groups. The before group was noted to be more white. There was noted to be less diabetes, more cardiac disease history, and the after ARIS group was more likely to have general anesthesia. Continued on this slide, the groups were largely the same. The only other significant difference was the after group was more likely to undergo a levator myopathy. For data analysis, the 2 groups were compared using student t-tests for the normally distributed continuous variables and Wilcoxon's rank sum test for non-parametric data. Categorical variables were compared using chi-square test or Fisher exact test. The length of stay was analyzed as both a continuous and a categorical variable, and multivariate linear and logistic regression analysis was performed to assess for possible confounders. This table shows us the results. It shows that there was a decreased length of admission with the ARIS protocol. There was also an increase in the number of same-day discharges, and there was an increase in the readmission rate. So this slide just summarizes those results. 25.9% of women were discharged, compared with 91.7% after ARIS implementation, and as the continuous variable, the length of admission also decreased for the ARIS group. Complication rates were similar in the 30 days following surgery, except for, as we said earlier, the readmission rate, which was higher in the ARIS group. Urinary retention was higher also in the ARIS group, 42.1% versus 23.6%. So the author's conclusion from these results was that implementation of an ARIS protocol in a Urogyn practice reduces hospital stay, increases same-day discharge with only slightly increased readmission rates. Some limitations of this study: there was no data on patient satisfaction or patient preparedness from the pre-ARIS group. The pre-ARIS group was also retrospective, and the study was not powered to detect small differences in the secondary outcomes, such as the individual complication rates. What is the clinical significance? It may increase uptake of ARIS protocols in FPMRS practices if their goal is to decrease hospital stay. And this study provided information on our Urogyn specific patient population, which had not been previously done. Some questions that came up included, what was the impact of the counseling of the patients and the setting of expectations? Because that was different in the post-ARIS group. And what would the impact of simply doing the counseling without the rest of the protocol have been? Also, would some of the pre-ARIS group have met discharge criteria, and how many?
Sorry to interrupt, but that's one of the main important points that I was curious about when I read this paper was, if you go to table 1 and look at their discharge, and I think we have the extraordinary privilege of the author being online with us, so maybe they can clarify. But on table 1, the discharge checklist says they've got the criteria here: tolerating oral fluids without nausea and emesis, pain control, pain score less than 5, which is different than what was stated earlier in the paper, which is less than 3. And so that discrepancy, I couldn't resolve it reading through the paper a few more times. And so I was wondering if the discharge criteria was pain score less than 5 or less than 3. But regardless of that, the other thing that struck me as I read this discharge checklist: tolerating PO, pain controlled, voiding trial complete, independent ambulation, and no signs of delirium, it would seem to me that there's a lot of patients who, regardless of ERAS, would fit that criteria on post-op day 0.
Yeah.
Does that make sense?
Yes.
And so that to me spoke to the idea that, well, a lot of what we're doing with ERAS is we're trying to look for a difference in outcomes. They've been easily demonstrated in other domains where there's a high surgical impact, like major GI surgery, laparotomy, that sort of thing. But I think it would be fair to characterize most urogynecologic procedures as largely low impact, with a few exceptions. And so it may be harder to find a significant difference or clinically significant difference when you implement ERAS in a population that's undergoing surgery that's not going to have a huge physiologic burden compared to some of the other major surgeries. So,
All elective surgeries for the most part,
right.
to enhance healthy population.
Any thoughts on that from the group?
Can you go backwards?
Hi, it's Sherelle. I can weigh in if you want. I think.
Oh, that'd be great. Thank you.
Yeah, thanks for asking me to be in the journal club. I think some of the points that you brought up are valid, and I apologize that the table is not correct, but it was pain score less than 3.
Okay.
And you bring up a really good point with patients more than likely meeting the discharge criteria in the pre-ERAS cohort based on that checklist. And because we weren't kind of standardizing criteria for patients to go home pre-ERAS, we didn't necessarily have this criteria. And to be transferred to the floor, basically you could go to the floor nauseous, you could go to the floor in pain. You just had to be, your vital signs had to be stable. And anesthesia said the wake score had to be 8 or higher versus 9 or higher to go from PACU to phase 2, but to go to the floor 8 or higher. And so I'm sure that the majority of the patients would have met a lot of this criteria, although I will say that I did another study about voiding trials the day of surgery versus post-op day one. And the patients who had a hard time, we found passing their voiding trial the day of surgery were patients who had pain and nausea. And so that was kind of what really pushed us to move forward with ERAS, is in that small percentage of patients, you know, maybe 10 to 20% who have pain and nausea in the PACU. Is there any way to kind of get rid of that before surgery or perioperatively so that they can go home? So I think you're right. The vast majority probably would meet this criteria. And that's what's hard with these studies. I mean, clearly you're like, oh, yeah, you told patients they should go home. There's ERAS. Of course they're going to go home. It's kind of obvious. But you have to pick something to measure objectively when you're implementing a pathway like this. And so the focus of the institution, you know, was same-day discharge. And then a lot of the other studies have used satisfaction. We always hear about complications, so we included that. But some of the criticism of this study has been, you know, our primary outcome, which, you know, seems somewhat obvious or maybe intuitive with implementing the protocol.
That's a very good point. I mean, it strikes me that there are other studies that, I guess, you know, patient-reported pain scores and patient satisfaction are actually completely divorced outcomes. And that speaks to the fact that I think enhanced recovery is more than just an algorithm of medications and recovery milestones. The part that's not actually being talked about with enhanced recovery is that it involves other things, like there's enhanced communication, there's enhanced communication with the patient, there's probably enhanced communication between the surgeons and the anesthesiologist. And some of that's going to filter through and have an effect on patient outcomes. And so when you realize that you have studies that, similar comparative studies that show that pre and post ERAS pain scores don't change whatsoever, but then patient satisfaction scores are higher in the ERAS group, even though their pain scores are not any different. And so this idea that if the patient perceives that you're doing everything you can to control their pain, that almost matters more, just as much, than if you were just giving them pain medication. So I think there's a definite unmeasured quality or property of the ERAS, you know, program. And I think that's what we're detecting with our numbers here.
Yeah, I definitely agree. And I think we tried to hit on in the paper and the discussion, you know, patient expectations, building those ahead of time, reinforcing the message, you know, we're doing the special program to improve your pain, to hasten your recovery, to get you back to normal. You know, at our institution, the institution I was at, we brought them back for a preoperative appointment where we didn't have those before. So the patients were able to come back again, you know, with their family member, ask their questions, review kind of what was going to happen the day of surgery. And so an interesting point here is you saw too, the post-operative calls after surgery increased after ERAS because, again, they weren't getting probably as much counseling in the hospital. And so it increased some of that on the phone, I think, after. And so I think communication with the patient, making them feel heard and like they're going to be taken care of is really important. But also, like you said, the connection between the surgeon and the anesthesia and perioperative nursing, you know, everybody was meeting and kind of, there were so many meetings and talking and in constant communication. And when you're checking and assessing your milestones and your objectives every 3 months or so, everybody's on the same page, working towards the same goal, it does improve communication within the teams as well. So I think both of those are really good points.
Right. So almost like a performance bias or an observation bias that's somehow being captured. Okay. The other thing that I thought was interesting was that the pain scores in this study similarly were not different between the two groups. I think they were reporting a pain of about 3. Most patients, both cohorts, were reporting a pain of 3. And so again, in this case, it looks like the pain scores was not different pre and post ERAS. Okay. And so my question for you, Kyle, is what do you think about the readmission rate issue? There was a baseline assessment, and then they saw that readmission rates went up. Now, they cited a separate study that said that looked at post-ERAS outcomes in a minimally invasive GYN group and said that the rate was similar. However, and you may not have read the study, but in that study, yes, the readmission rate was about 6.7%, so very similar to what they had. But in that study, the readmission rate had not changed at all. It was not statistically significant. How would that affect your interpretation of this study finding?
Right, well, it makes me, well, I wanted to take a look at the reasons for the readmissions, which from what they talked about in the paper, none of the reasons that they gave seemed to really logically correlate to the protocol. So I'm not sure I can take a lot from that readmission rate.
Okay. All right.
Yeah, and that's the
thing I'll ask about the readmissions, which is not in the paper, is a lot of those were in July and August, which is like new fellows and new residents.
That's the other factor in the ERAS protocol that needs to be taken into consideration, right? Time of year.
So there needs to be like a July ERAS and then that's different than light versus full ERAS.
But so that was like the cuff and the trocar hernia. But then the ureteral clots or the ureteral obstructions, we stent patients and had routinely stented patients for prolapse procedures, sacrocolpopexy and vaginal procedures. And because the patients maybe were getting less fluid during surgery and then going home at night and not getting as much fluid, they ended up with fibrin clots in the ureters. I mean, it was like 3 or 4 patients kind of in a 2 or 3 month period. And so what we started doing was hydrating patients who had hematuria postoperatively after stent removal and making sure their urine was clear before they went home. But that was something we thought was directly probably related to ERAS, because when the patients were in the hospital, we kind of watched their urine overnight with the Foley to make sure it cleared up versus when we sent them home, just as an FYI.
That's interesting. That's very interesting.
Yeah.
Yeah.
I guess before we go to the next paper, if anyone else has any comments, I can read there's been a couple of comments here that have filtered through. So one from Stephen Monoglia: the practice of urogynecology has encompassed MIS and ERAS for quite some time. ERAS is a term we now apply in order to evaluate and manage our efforts for a safe and efficient recovery after surgery. This single solitary term applies to a multifaceted approach to patient care that involves a large number of stakeholders, including but not limited to patients, surgeons, and anesthesiologists, nurses, hospital insurers, other communities. And then there's a comment from Derek Sanderson. So if you discharge patients, most will go home. These are non-contemporaneous cohorts, making it difficult to evaluate the ERAS protocol over the change in the practice regarding routine discharge. That you're right, and I think we've kind of discussed that. So let's go to the next article. Let's see if I can get that to load up.
That was an awesome review of that paper. Really great insight.
Yeah.
This is going to be faster.
Thank you for being here, Cheryl.
Yeah, that's great.
My pleasure.
And we have Cassandra as well.
Wonderful. That's great.
Okay. So now I'll hand it over to Dr. Wong, who will present same-day discharge after robotic assisted sacrocolpopexy.
Okay, so this is the overview of the objective sample methods, analysis, results, and discussion. So we picked the paper, same-day discharge after robotic-assisted sacrocolpopexy from Duke. The objective was to, the primary aim was to compare unplanned post-op encounters in women discharged same day versus later after robotic sacrocolpopexy. And the secondary aim was looking at unplanned post-op phone calls. When we're talking about post-op encounters, they were looking at unplanned physician clinic visits, ER visits, urgent care visits as well.
Yeah, you can actually move that over so you can see.
Actually, I have the slides here. Who were the subjects? These were women who were undergoing robotic secretopexy with and without hysterectomy for prolapse, and they also included vaginal surgeries for prolapse or incontinence. The only exclusion criteria were any concomitant procedures done by another service that acted as primary. So these were all basically surgeries that were performed by the FPMRS attendings out of the Duke FPMRS division. So these were the baseline characteristics that were recorded. They looked at the race, BMI, parity, medical comorbidities, surgical history, POPQ, surgical procedures, and ASA class, as well as looking at preoperative, perioperative data. So looking at the estimated blood loss, the fluids administered, any intraoperative complications. They looked at surgery start time, procedure duration, PACU time, and narcotics and any antiemetics received. So this was the chart. And further. So the method, this was a retrospective cohort study that utilized an integrated medical record system that was implemented shortly before their the start of their cohort study. Slide there. And with analysis, they used the chi-square test for categorical measures, student t-test for the continuous measures, as well as the logistic regression models looking at the variable outcomes between the two cohort groups. And so results, 272 women met inclusion criteria. There were 80 or 29% that were discharged same day versus 192 or 70% discharged on post-op day 1 or later. Of those, 187 were discharged on post-op day 1, 5 were discharged on post-op day 2, 2 had respiratory complications, 1 had a pulmonary fibrosis, 1 was a morbid obese with limited mobility that needed additional physical therapy, and 1 had uncontrolled pain on post-op day 1. And the results regarding unplanned encounters were essentially the same, as well as their routine post-op visits and unplanned phone contacts were not statistically significantly different. So they looked at on-call, MD calls, and nurse visits. So the results were on same-day discharge. These patients tended to be older. They tended to have lower BMI. They had a history of prior hysterectomy. These were cases that typically started before noon, and these patients typically had a concomitant neck surgery. Also for same-day discharge, these patients were less likely to have prior abdominal surgery, and less likely to undergo lysis of adhesion, sling, or posterior repair. They tend to have lower estimated blood loss, less fluid received. Their procedure times were shorter, and these patients tended to spend more time in the PACU. So the results were no differences in unplanned provider visits in the 6 weeks after surgery. There was no significant differences in unplanned post-operative phone calls in the 6 weeks after surgery. So the author's conclusion were that same-day discharge after robotic sacropexy did not increase post-operative healthcare utilization. So discussion, this was a comprehensive perioperative data that was collected on these patients. And so there was a lot to compare between these two cohort groups that you could see. But some limitations of the study was, number one, this was a retrospective data. So there's the limitations with retrospective data collection and looking at relations. Also, they've mentioned about individual physician practices, that 1 out of the 5 attending surgeons tended to send his patients home on same day after these kind of surgeries. So that may have skewed the results, and as well as bias that could have occurred that we can't account for in the data, such as selection bias or surgeon bias of these patients that were selected prior to same-day discharge versus going home on post-op day 1 or later. So,
questions. So in this study, we had a binary outcome, right? Because unplanned versus no unplanned patient visits or provider encounters. So what do you think? Is that a good, what do you think of that as a surrogate indicator for healthcare utilization? In what ways is it good? And what ways is it a limited outcome, do you think?
So unplanned visits, I think it's one-sided. I don't think you could account for maybe the patient experience as far as for discharge, because I think we touched upon that with the ERAS paper about if patient satisfaction scores and how they may feel about same day versus. But as far as the binary outcomes for this, I think that it's good, but I don't think it's comprehensive enough to.
So you're limited to retrospective paper. So, but what I'm getting at is just sort of the generalizability of the findings. If you're going to be limited by the retrospective nature, and then the outcomes of the study too sort of constrain the degree to which you can make an interpretation of the findings as it applies to your own practice. So, so yeah, I mean, I think it's a good surrogate indicator for healthcare utilization. It's certainly one that we know eats up resources in the office and is something that we have to account for. But obviously, if there were other studies that gave us more expanded healthcare utilization outcomes, which would be, going straight to the meat of the matter, which would be actual costs. Like, what is the cost of same-day discharge? I think that would actually have probably more of an interpretational value to your own practice than phone calls. Does that make sense?
Yes.
So it's not so much as the outcome being bad or good. It's more of like, how far can I generalize this to my own practice or to my own clinical practice based on what outcome they defined. And then another interesting finding here was that the same-day discharge group underwent half the number of slings, if you go back, than the post-op day 1 group. But they also mentioned in their methods that they considered follow-up visits with voiding trials as planned, not in the primary outcome. So what do you think about not including voiding trials as part of this outcome? You could make the case, correct? Potentially that it is. You're trying to measure cost or effort to take care of the patient after they've gone home. So I guess what I'm getting at is how many of these voiding trials were because the patient didn't pass an active bladder trial right after surgery. In that context, it would not be planned, right? So,
exactly.
So what do you think?
So I think their voiding passage rates between the same day and later days were roughly this, like again, it was 74% versus 70%. So for voided trial passage. So I think counting that as an unplanned would not be significant.
Okay. And then the other thing I noted was that there was an age difference, right? So a significant. So the same-day discharge patients were a little older.
Same-day discharge were 61 versus 58. It was considered statistically significant. I think clinically not significant.
Right.
So some of this data may not be applicable.
So in your mind, there wouldn't be some sort of magical cutoff that somebody who's less than 60 should, right?
Between 58 and 61. I mean,
Right. There's no biological plausibility, but I'm predicting based on that alone, most likely that's going to.
Oh yeah.
Okay. So let's see. So we have some comments here, and yeah. So Stephen Monaglia, postoperative office voiding trials definitely increase healthcare utilization. So it's true. I mean, I think a case could be made too for including those, but I think they really wanted to focus on unplanned visits as an outcome. But again, without them really unpacking which of these, because it depends on how you define planned, right?
Yes.
So she failed her bladder trial right after surgery. So we've planned a voiding trial in the office. So that could definitely skew your results one way or the other.
But still use resources and the patient has to come back.
Right.
Yeah.
I think that one of the main issues with bias that we see in the paper note is when they talked about that there was already one person, one surgeon was already sending all of their patients home. And so in my mind, when I was first reading this, I was thinking, okay, were they practicing their own version of ERS? Are we comparing, you know, something apples to oranges here? Because they've already started to preset expectations or start to set themselves up even by, you know, guiding maybe some anesthesia in that way too. I mean, it's kind of like a mindset. So that was the main question that I had. And it goes to to speak to the, you know, the limitations of what we have to work with. But that was one of the questions that I had in my mind. Maybe we are comparing not this, you know, somebody's ERS to a non-ERS group per se.
So they're right. There's this a priori mindset amongst the OR team, like, oh, this patient's going home today, so we better blank, 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 right? So it just sort of, it frames the type of care potentially that you're going to provide, the things you're going to do.
Potentially.
Right.
Seems like, this is Tom here, it seems like the expectations portion of all this is kind of a common theme that sort of is driving how people can make it so that the discharge is both patient satisfier as well as, you know, potentially a decreased or at least cost neutral healthcare utilization prospect.
It's Steve here. I'd like to address what Leishan just said. And you know, our hospital just started an ERS protocol for gynecologic services maybe a few months ago, but I realized at my own practice, the difference between the protocol and the order sets really wasn't that much, and that a lot of our patients are already going home the same day. And you'll look at the order sets and some of the medications that they're adding are just a few things like celecoxib or gabapentin, for example. But what is really deep in the discussion here is, you know, if the nurses believe the patient can go home and try to strive for that, if the surgeon believes that, and if the patient believes it, I think that's it. That's probably the most important thing. That's very difficult to study. And then the catheter issue, whether or not they fail a catheter, or the voiding trial rather, one could argue just sending automatically everyone home with a catheter. I'm not advocating that, but obviously you could kind of see the logic to that. But then that's going to increase office utilization, put us behind schedules because we're constantly going to be doing voiding trials in our own offices. So that's not something we want to do. But that kind of trade-off between hospital-based and office-based voiding trials is definitely going to be the next area, I think, that we're going to have to figure out in order to get ERS to be very successful.
Right.
I agree. I think the buy-in at all levels is definitely where it comes in. I mean, the setting up of expectations at all levels of patient care, from the moment that they're admitted to the moment that they're actually, you know, in the recovery room, to how that progression goes, is going to be a lot of what, and that's, I agree, we cannot really measure that. I mean, everyone needs to be on board.
Yeah. Yeah, I mean, I think the other thing is, I think about this, but there are also some non-modifiable things that I think are going to be just intrinsic, you know, obstacles to same-day discharge. So, I mean, we still have patients who live far away and are not going to be comfortable with going home. We still have age-related concerns as well. So, and understanding that our patient population is very specific and leans toward this age group, there's also sort of a pre-existing mindset, because there's a front-loaded cost too, because I think most patients are coming through the door to see you, they're going to have surgery. And so we, you know, in that survey that we sent out, the interest from patients that was perceived by the people who were participating said that they were somewhat interested. So there's work there to be done too. So the counseling that's up front for the de novo surgical patient who you are now about to explain why it's safe and okay to go home, there's that cost to account for too. And, you know, in many situations with clinic, the way it goes, if it's busy, if you're running behind, that becomes a challenge. So.
There were a couple of comments earlier on that may apply to what we're talking about.
Yeah, let me borrow that here. So, let's see.
It talked about same day going home and hotel vouchers, and Steve mentioned something about the islands going home.
Yeah, let me actually just read this most recent comment, and then I'm going to go back. So we have Alex Berger, who said, excellent discussion. Thank you. Important to consider a range of value-based care outcomes. Agree. Patient-reported outcomes, complications, readmission costs. Yes. Let me just go back. There's something about, right, hotel vouchers. Oh,
Cassandra, who is the author of this paper.
Right. So she says our patients do the same at Mayo. They often stay in a hotel for a day or two after surgery before flying home. I'm curious if hotel vouchers would have an impact.
That's
a good question. Yeah.
Great discussion, guys. I was waiting for a pause to make a couple of comments, but
go ahead.
Go ahead. Thank you.
Yeah, so just for a greater context of when the study was conducted, actually we had our gynecologic oncology division had implemented ERAS during this entire study period, and so urogynecology was more or less following the ERAS protocol during this entire study, but the goal wasn't necessarily same-day discharge. There was never a push. It was very attending dependent, and so some people bought into it, some people did not. And I think over time, as we showed that it didn't increase burden, like the fellows weren't getting more pages overnight, there weren't more urgent care visits and other things, more people started to buy in. And currently, I think the practice is now that almost everyone, unless there's a certain contraindication for the particular patient, sends their patients home same days after robotics, like colpopexies. And so that was when I was a resident back at Duke, and now here at Mayo, it's something that we're starting to dip our toes into as well, expanding the ERAS protocol and pushing for same-day discharge here as well, which hasn't been the standard practice yet.
With including robotic circulopexy there too, Cassandra?
Yeah, so I think up until about 2 years ago, no robotic cases went home same day. And now that the ERAS protocol is starting to become more of a universal practice here, and we combine gyn-onc and urogyn into GYN services, we're starting to consider more on a case-by-case basis with the hopefully that we'll now implement it universally for all patients as we're able. But we do have that limitation of patients coming from afar. So some of our patients are coming from California or Florida and other places, and they're coming, the night before, staying in a hotel, and then have their surgery. And then there's this question of, do we then send them home to a hotel, or do we keep them overnight for a night? And cost-wise, I think the more cost-conscious thing would be, if they're medically ready, they could go to a hotel.
Yeah. That was going to be my point, is that the cost analysis there would be really interesting to see.
Right, because they don't need, if they could just, they just need a place to sleep. We're talking about not utilizing 24/7 of nursing and picking up an OR room and not needing to have labs drawn or vitals checked every 4 hours. So it's a vast difference.
That's something we're selling to the patients too. You'll be more comfortable in a regular bed. People aren't going to be waking you up. You can eat and drink as you please. You'll probably walk more and have better outcomes. And so, I think Mayo is looking into that, whether or not they can have hospital-sponsored hotels, and if that would help.
Can I have you back up to one of the results that came up? An interesting thing, because it's very hard to change practices based on reading a couple of different articles, but we can at least take some learning points. And one of the things that I learned from this article was the whole issue of patients were more likely to go home if they were done before noon. And so that made me, consider, well, that's actually an interesting point, because you can actually schedule your OR day slightly differently. And your big cases, for example, can be done first, versus if your anesthesiologist is on board with your patient not being NPO for 12 hours, then your 3 p.m. sling can still have something to drink at 7 in the morning. It's like I said, that in like one of the articles in their introduction talked about that not being NPO and allowing people to drink and not being like in starvation mode is one of the changed.
Right.
And it's been, it's opened up my eyes to start thinking about these different
aspiration.
And no aspiration with any of these, exactly, because that was something that we all fear. And so that's, yet another opportunity for us to, expand and consider. Obviously, all of these things need to be studied by, in a wider, in different kinds of settings to be operationalized. But I think that those are just the kind of things that we can learn even from studies that have, XYZ limitation. I think that there's a lot to learn from all of these cases and these reports that are being published.
Great. Leisha, that's a perfect sort of summary of sort of what we just discussed and who might be implementing as we go along. And so I wanted to interrupt just because we've got like 3 or 4 minutes left, and I just thought that we could use this as a stopping point. I thought this was an awesome discussion. I really, really appreciate the authors of the papers being present and engaged, and I just really thought this was a great discussion, and I appreciate everybody's attendance here, and I'm hoping that we can continue to grow what we're doing here. The next one, as I remind you, is December 3rd, 5 p.m. Pacific time, 8 p.m. Eastern time. We'll let you know what the papers are, but I really think that this is kind of fun, and I appreciate the engagement. And yeah, thanks to all of you.
This is great.
Yes.
Thanks.
Thank you.
Thank you, guys.
Those
Bye,
not
guys.
can
Thank
find
you.
the recorded journal clubs on the FPMRS.net website.
Oh yeah, thanks, Steve.
Under the media tab.
Okay, awesome.
Excellent work, everyone. Thank you so much.
Thanks.
You can log us.